Hello, everybody. A very warm welcome to all of you to the global launch of the Lancet Regional Health Southeast Asia and the Lancet Global Health Series on primary healthcare in South Asia. Uh, First of all, a bit of an apology for the delay in starting up. We've been having some connectivity issues, but we're underway now, and we're looking forward to this exciting series that several of us here have worked together for the past almost 2 years. Uh, so I wanted to introduce the two editors who have been helping or editing this, leading this series from the Lancet. The first is Shalini Garg, who's based in India, and she's the editor of the Lancet Regional Health Southeast Asia. And the second is Kate McIntosh, who is the deputy editor for the Lancet Global Health in the UK. Unfortunately, both our editors are having connectivity issues, and I'm hoping that they are able to join us soon. But in any case, I think the best thing is to do for us to get underway, and hopefully Shalini and Kate will be able to join us as soon as their internet starts functioning again. My name is Krishna Rao. I'm an associate professor at Johns Hopkins University. Before we begin, I'd like to go over a few housekeeping rules so that everyone has a chance to participate in this webinar. So starting, you're all welcome as attendees to submit questions throughout the presentation. There's a question box on the dashboard. You should be able to see that on the right of your screens. So please type in your question, and we will try and answer it as the webinar goes on. Secondly, on the webinar dashboard, you'll see a box with related resources that links to related content, including a link to the full series that will take you to the Lancet.com website, and you can access the entire series, that is the 5 papers of this series and several commentaries from there. Also, you can adjust or minimize any of the boxes on your screen as they appear on the webinar dashboard to suit your preferences. So for example, if you want to increase the size of the chat box, you can do so so that you can see questions and so forth. Then there's a link to the on-demand version of the webinar that will be emailed to you once the event has concluded. So if you would like to have a recording of the webinar, there's that link you can click on. And so finally, from the Lancet editors, there's a request that once the webinar has ended, please complete their 30-second feedback survey so that they can continue to improve their webinar offerings. So these are a few of the housekeeping rules for today's webinar. And I'll next talk about the agenda for today. As you can see, there was a welcome by Shalini and Kate, the editors from the Lancet for this series, but unfortunately they are unable to join, and hopefully they'll join us shortly. I'll start with introducing the series, and then we will go into discussing each of the 5 papers. So the first paper that we'll talk about is on the state of primary health care in South Asia. The second would be on reorienting South Asia's primary healthcare system for non-communicable diseases. The third paper that we'll discuss would be on improving urban health through primary health care. The fourth one would be on strengthening PHC through community health workers. And the last paper we'll discuss is reorienting health systems towards comprehensive primary health care, which is a summary paper of the series. After that, we'll have a question and answer session that will be moderated, hopefully by Shalini and Kate. If not, I'll step in. And lastly, we'll have some concluding remarks. So this is the agenda that we're going to follow for the next, for this webinar. And as I said before, please feel free to add your questions into the chat box, and we will answer them. I'll now like to take this opportunity to introduce our speakers. I'll call each one of them by name so that we can follow a particular sequence. I'll start with myself since I'm Krishna Rao. I'm an associate professor at Johns Hopkins University, and I led the series. Shankar?
Sure. Hello, everyone. My name is Shankar Prinja. I work as a professor of health economics at PGI Chandigarh in India. I led the paper 1 of the series, which was on the state of primary healthcare.
Elena?
Hello, everybody. My name is Elena Adams. I'm an associate professor and the Global Health Program Director in the Department of Family Medicine at McGill University. And also, I'm adjunct scientist at the ICDRB and international professor of public health at BRAC University, both in Bangladesh. And I was involved in the paper on NCDs as well as the urban paper.
Thank you. Kausar Afsana?
Hi, I'm Kausar Afsana. I'm a professor at BRAC James P. Grant School of Public Health, BRAC University, based in Bangladesh. My paper is paper 4, which is on community health worker.
Sudha?
Hello, I am Sudha Ramani. I'm an independent consultant right now. I work mainly on health policy and systems-related issues on specifically related to primary healthcare. In this series, I've been involved in the last paper, which is a synthesis paper of the series. Thank you.
Susie Pereira?
Hi, I'm Susie Pereira from Sri Lanka in the WHO country office. I'm a public health specialist and I've worked on the last paper, paper 6.
Thank you. And Manoj Virasinghe?
On community health workers. At present, I am attached to the University of Coventry in UK, but major work was done when I was there in Colombo Medical Faculty, where I have been working very closely with community health workers. Thank you.
Okay, so with this introduction, thank you all. I will start introducing the series. So I think a question to ask is why a series on primary healthcare and why on primary healthcare in South Asia? So our thinking of doing this series started when we felt that the many challenges that South Asian countries face, many health challenges, that the primary healthcare approach offers a cost-efficient way of addressing these many challenges. And so from that belief or from that point is where we thought that it'll be important for us to work on a series that captures the experience of this region in terms of its primary healthcare experience, but also that is future looking. How can this primary healthcare approach, for which this region has been an innovator in many ways, how can it help address the future problems that this region will face? And there are many common problems, shared common problems, I should say, that this region faces, both in terms of epidemiology and demography. There's a high burden of communicable and non-communicable diseases and injuries. Populations are aging across the region. In some countries like Sri Lanka, it's ahead of others in the region. There's rapid urbanization throughout the region too. So many of these common health issues are challenging countries in the region together. And all of the countries in the region also face large inequalities in health and the social determinants of health. Quality of care has been another issue that has been pointed out by various researchers as being a major issue for people, particularly from lower socioeconomic groups in the region. And then the region also is well known for low levels of public financing of healthcare, and consequently, there's a large out-of-pocket burden on patients, particularly those from poor economic background. So all of these create a sort of a shared destiny for countries of the region. And so it was important, I think, as we were thinking through this series, of how can the primary healthcare approach address these myriad problems that countries in the region face. It's also important to say that the region and countries in the region have a rich history of PHC policies and innovations, but there's also an understanding that implementation of these policies has not been very good. There have been exceptions, of course, but in general, the potentialities of the primary healthcare approach, that hasn't been exploited to its fullest. And we believe that stronger primary healthcare oriented health system in the region can help this region address all of these health concerns and more. And finally, one of the things that we were hoping that this series achieves was to stimulate future thinking on future models of primary healthcare. As many of you would know, the primary healthcare programs and models in the region, as in many other LMIC countries, has focused largely on communicable diseases, maternal child health conditions. And these are still important in the region, but now we have NCDs coming in a big way. And so how can our primary healthcare systems deal with all of these challenges together? So we felt that this was an opportune time to think about what future models of primary healthcare in the region should look like. And also given these future problems that will afflict countries in the region, things like aging of population, rapid urbanization, and so forth. So with this thought, we embarked on this series about 2 years ago. As I said earlier, there are about 5 papers in this series. I've already mentioned the series papers. There are 5 of them, and you can see on your right the titles of these papers. And we'll be discussing each one of these in today's webinar in more detail. And a good question at this point is to ask, what are the new learnings that we've got from this experience together? And it's important to note also that the people who came together for this series were drawn from various institutions in South Asia and beyond. And so we'll hear more about the new ideas and learnings that we've had in this series. But very broadly, we did this. The ideas that in this series, they relate to innovations in the region, successes in PHC implementation, what sort of future models should countries in this region adopt, and what kinds of cross-learnings are there for informing these future models. Researchers for these series came from several institutions. In Bangladesh, we had James P. Grant School of Public Health at Brack University. In India, we had the Postgraduate Institute of Medical Education and Research in Chandigarh. In Pakistan, it was Aga Khan University. In Sri Lanka, it was Department of Community Medicine, University of Colombo, and the WHO Country Office. And globally, there was Johns Hopkins University, McGill University, and the National University of Singapore. And there were others too who were co-authors on these papers. I think it's important to also acknowledge the support that we have received for this series from the WHO CRO office. They have been very generous in the support that they've given us to conduct this series, to have our meetings, and to publish these papers. So a big thank you to the WHO CRO office. I'd also like to thank the editors from the Lancet who have been tremendous in supporting us through this not so easy process of producing these 5 papers. So big thank you to Shalini Garg, a big thank you to Liam Messin, and to Pingwei from the Lancet Global Health. Okay, so with that, let's embark on discussing each of these series papers, and then looking forward to the question and answer. So our first presenter would be Dr. Shankar Prinja, who is a professor at the Department of Community Medicine, School of Public Health, Postgraduate Institute of Medical Education and Research in India. And the paper his paper that he led on was the state of primary healthcare in South Asia. Over to you, Dr. Prinja.
Thanks, Dr. Rao. With that nice introduction, I'll begin a little bit description of the paper 1. So, as Krishna has already mentioned, that the whole idea about this series was also to look at some of the commonalities across these countries, which have been experiencing a transition in terms of the epidemiology of the diseases. There's been an aging of population. There's been a rapid urbanization. All of these factors influencing the way that you organize your primary healthcare. And while each of these countries have had some experiences in terms of improvements in overall economy, there have been, at varying degrees, some socioeconomic inequities that have existed. And these regions, each of these countries have certain commonalities in terms of the way that they've organized their primary healthcare system, but they've also taken a significantly different trajectory in terms of the growth and the pace of progress, which we can see in the table on the left side, which shows that the various indicators, whether you talk about the demographic status, the economic status, some of the markers of primary health care or vertical programs, they are at different levels. So while we do recognize that there are similarities, there is also a varying degree of progress across these different countries. And in order to write this paper, we were looking at two things. One, to set the context of the series. In this paper, we describe the overall existing status of the health systems that have been created for delivering primary health care, and also to appraise this system in terms of the strengths, weaknesses, opportunities, and threats. And we used primarily the framework which has been described by the WHO and the UNICEF in order to measure the primary health care, which basically illustrates the primary healthcare approach in 3 broad domains: the integrated health services, the empowered communities and people, and the multi-sectoral policy and action. And there are various indicators, both quantitative and qualitative, which try and describe the overall performance. So with that in mind, we did a literature review of published evidence. We also accessed various global and national data repositories in order to document the performance of primary health care. We also used each of the authors. They undertook an extensive review in order to elicit the experiences, in order to solicit responses from key stakeholders within the individual countries on performance of primary health care. And finally, we brought this all together in a virtual consultation of about 33 global and regional experts to present the findings. And broadly, we present our findings in the paper in terms of describing first the type of healthcare facilities that have been created to deliver primary healthcare, which are at the level of community, the primary facilities being the ones which are the first point of contact with the health system, and higher primary are the first referral points. Broadly, we find that in the region we have a mix of public and private provisioning, with predominant public provisioning of preventive services and a lot of outpatient care being actually sourced from the private providers. And while the the government structures for provision of primary healthcare seem to be relatively much more well defined. The private sector has a very significant heterogeneity in terms of the level of providers, in terms of the range of services that they offer, and in terms of the accreditation. And there's a wide array which is also beyond the typical private provisioning, which is more into the traditional, complementary, and alternate providers. And then we also, within the paper, describe the kind of commonalities that exist and some of the differences across the healthcare providers or the human resources for health that exist for providing primary healthcare. For example, if you look at this table, we see that the point at which you actually have a medical officer or a doctor providing healthcare is much more proximal in Sri Lanka, whereas in India and Nepal, the medical officer led provision of healthcare services actually begins from the higher primary level. So there are some of these commonalities, but then certain differences. We also describe the essential services that are part of the package, some of which are explicitly stated, which are shown in the blue color of the table on the right side, some of which may not be explicitly stated, and some others which are actually provided in certain regions or provinces within the country, but not necessarily nationally. Broadly, the message is that several of the reproductive, maternal, child healthcare services are found consistently across all levels of primary healthcare within the health benefit packages. In terms of the non-communicable diseases, while health education and counseling have gradually been incorporated, beginning from even the community level provisioning, and the screening and management have varying degrees of progress in terms of their incorporation as well as coverage. And finally, we define what are the various the enablers and the barriers towards success of primary healthcare. So the ones in the green on the top are those which are the enablers for primary healthcare, and the ones on the in the light pink color down below are the ones which are the challenges that need to be encountered. So basically, we have several important enablers within the region, including good, vibrant civil society, inclusion of performance-based incentives for health workforce, gradually introduction of digital technologies. But then there are a lot of challenges. Even, for example, if you look at the data challenges, which is in the last two boxes, one of the challenges we recognized was that while there is a good HMIS system that records the provision of healthcare services, the extent to which there is a provision of such information by private providers remains relatively limited, which becomes a challenge in terms of monitoring of healthcare services. So finally, these are the final key messages from the paper one, which talks about the need to address the rise in non-communicable diseases, need to contextualize the primary healthcare services, and each country presents its own set of challenges. The urban healthcare was identified as one of the major areas which requires innovative thinking in terms of delivering primary healthcare. We recognize that while there are inequalities, the regional level inequalities are by far more than even income or gender-based inequalities. Private sector definitely is a area which needs to be strengthened and engaged with for better effective delivery of healthcare services, but its quality and overall regulation also needs adequate attention. So with that, I think I'll stop, and I'll now invite the next speaker, who's Elaine Adams, who's an associate professor at the Department of Family Medicine, McGill University, to take us through the next paper, which is talking about the non-communicable diseases.
Thank you, Shankar. And yes, this paper digs deeper into the challenge of non-communicable diseases, NCDs, in the region from a primary healthcare perspective. I'm presenting on behalf of an expert group of researchers and practitioners across the region, led by my colleague, Dr. Masood from BRAC University in Bangladesh. And for this paper, we reviewed the existing literature using a modified scoping review approach, and we extracted, synthesized, and analyzed the latest knowledge on the NCD situation in 5 countries, India, Nepal, Bangladesh, Sri Lanka, and Pakistan. And we focus on 4 NCDs, in particular, their major causes of premature death in the region: cardiovascular disease, chronic respiratory disease, diabetes, and cancer. We also considered promising innovations at the primary healthcare level in terms of non-communicable disease service delivery, and we also looked at national level NCD policies and their implementation. So in terms of burden, as referenced earlier, there is a rising non-communicable disease burden in South Asian countries with a disproportionate impact on disadvantaged and marginalized groups in the region, and it requires urgent attention. In the first graph, we see how the NCD share of total mortality is very high, ranging from a low of 55% in Pakistan to 82% in Sri Lanka. In terms of disease prevalence, in the second graph, we see that cardiovascular disease is the highest, followed by diabetes. We also note an elevated risk of the 4 modifiable risk factors: tobacco and alcohol use, poor diet, and physical inactivity. So we argue that primary health care is the ideal window to mitigate the NCD burden. Historically, primary health care has focused on infectious disease and maternal health and rural service delivery. In the context of rising burden of NCDs, we argue that PHC is really the ideal window for prevention and control for a number of reasons. First, it supports first contact, continuous, community-based, person-centered care that's critical to NCD prevention, screening, and management. Secondly, we have an aging population in the region with increased multimorbidity, and that's best served by a holistic, integrated primary healthcare approaches. We note also that primary healthcare focuses on equity, and this is important because of the rising burden of NCDs among those experiencing poverty. And then finally, that primary healthcare is cost-efficient and effective in terms of delivering NCD services, given opportunities for task shifting, mobilizing community health workers, engaging communities to care for their own health. In our review of policy documents, we noticed an impressive political commitment to prevention and control services for NCDs at the PHC level, but weak implementation. Consistent with the primary healthcare approach, countries in the region have adapted the WHO package of essential NCD interventions for national implementation. They're committed to multi-sectoral NCD action plans, and they recognize the need for a health and all policy approach. However, implementation is sluggish and uncertain. There are shortages in human and financial resources, poor capacity in terms of frontline health workers, insufficient infrastructure in some cases, and also interruptions in the supply of essential medicines and technologies. And all of these impede service delivery. So we argue that we need to reorient and resource integrated NCD services. And that includes the following: investing in health systems readiness, including information and surveillance systems, increasing government expenditure on primary health care, and in fact, dedicated financing to that, training primary health providers to detect, screen, and diagnose NCDs, task shifting to non-physician cadres such as community health workers and paramedics, supported by training and supervision. And then finally, leadership and governance at all levels of the system to ensure sustainability, especially given the major role of private and non-governmental organizations in service provision. Centralized oversight and governance are particularly crucial here. On a positive note, our review also noted some really promising interventions at the community level, such as community awareness programs via radio in Bangladesh, non-pharmaceutical intervention modules for diabetes prevention developed for junior public health nurses in Kerala, first level contact and follow-up by community health workers in Nepal, but issues of scale remain a challenge. In terms of technology, medicine, supply issues, these also warrant mentioning. South Asian countries have jump-started the use of information and communication technology to extend NCD services to rural, remote, and hard-to-reach areas. And in our review, we noted the huge potential of ICTs mHealth, telemedicine, electronic records, digital platforms of various kinds, and their suitability for accommodating the realities of low resource settings. However, there are issues of interoperability of data platforms, and that really requires high-level buy-in and involvement of diverse interest holders in systems development, especially in the context of pluralistic health systems. In terms of essential medicine diagnostics, we found that greater investment is necessary to ensure supply at the primary healthcare level, and that greater attention be focused on the rational use of medicines and community awareness to manage demand for NCD drugs. And then lastly, we argue that small-scale, fragmented, and pilot NCD interventions are insufficient. We really do need to focus more on multi-sectoral action to decrease NCD risk and increase equity. This requires motivated and strong leadership and across sectors to support a health and home policies approach. So we end the paper with with 5 key recommendations. First, the need to sustain political and financial commitment at the highest level with stewardship from the public sector, especially around multi-sectoral NCD plans. We need to reform, resource, and reorient PHC to deliver integrated NCD services. We need to expedite and scale the use of ICDs to support NCD delivery, especially in remote and disadvantaged populations. I would also argue in urban populations. And then ensure the uninterrupted supply of essential NCD medicines and technologies. Finally, to take action on those social determinants of health, which are so ubiquitous in the region, to reduce vulnerability and to increase access to services. So I'll introduce the next speaker, Krishna.
Thank you, Eleni. The next paper that we will discuss is on improving urban health through primary health care. And I'm presenting on behalf of several authors who contributed extensively to this paper. Urban health is going to be very important in South Asia. And it's going to be important in South Asia because of the sheer demographic of it. So, available data, and this graph here is from the World Urbanization Prospects, shows that by 2050, right, the share of urban population will exceed 50% in Bangladesh, India, and Pakistan, and will approach about 40% in Nepal and 30% in Sri Lanka. The sheer numbers of people who will be living in an urban area are tremendous. So, for example, 118 million in Bangladesh, 877 million in India, and so forth. And so, just by the sheer demographics of this, the cities of South Asia are going to have a very important role in improving and sustaining the region's population health. And so it became, therefore, very clear to us that a paper that discusses urban health and how primary health care can help address the health concerns of urban areas is critical. And I'd like to re-emphasize why the primary healthcare approach is important, particularly for urban health. The primary healthcare approach, as many of you would know, focuses on 3 pillars. One is on integrated primary care services, that is preventive, promotive, curative health services, but also on addressing social determinants of health and intersectoral action for health. And we strongly believe that to address urban health challenges in South Asia, in South Asian cities, this sort of multifaceted approach is both critical and necessary. Because the challenge, in our opinion, that South Asian cities face is to reduce health disparities, both in terms of living environments, access to healthcare, access to housing, sanitation, water, and so forth. And therefore, a broad, multifaceted approach like the primary healthcare approach offers a very important way or direction of addressing these multiple challenges. we start this paper by examining the health in urban areas of South Asia. It's important to note at this point that there isn't a lot of data on the urban experience in terms of health. And what we have here in this graph is a compilation of information from various sources. So if we start by looking at infant mortality rate, one sees that it varies considerably across countries in the region. Sri Lanka stands out, of course, as an exception to this, with the lowest infant mortality rate in urban areas among countries in the region. It's worth noting that the average infant mortality rate in urban Sri Lanka is better than the top 20% of the richest 20% of urban residents in all of the other South Asian countries. And these are people who have access to very good healthcare for the most part. And so I think in this respect, Sri Lanka's achievement, at least in terms of IMR, is quite remarkable. The other thing we see by looking at these differences, socioeconomic differences, is that there are large socioeconomic differences in infant mortality across countries in the region, and this is a problem or a challenge that needs to be addressed quickly. The second thing that we saw from this review was that it's not only infant mortality and there are differences that are there, but we also see that hypertension and diabetes is higher in urban compared to rural areas, though the socioeconomic differences in hypertension and diabetes is not that clear. Secondly, the other characteristic of service delivery in the region is that outpatient curative care is mostly provided by the private sector, and this is something that Dr. Prinja also referred to in his presentation. So across the board, you have upwards of 70% of outpatient visits being catered to by the private sector, and as we'll see, this private sector is not just the formal private sector, but also involves a large number of informal providers. And this is in urban settings where access to formal providers, these geographical access to formal providers, shouldn't be that much of a challenge. So related to this high levels of private healthcare use and low levels of prepaid healthcare, we see that catastrophic health expenditures, which is an indicator of financial hardship, is quite high in urban areas of South Asia. So in Nepal, India, and Bangladesh, upwards of 10% of the urban population is estimated to face catastrophic health spending, which is they're spending more than 10% of their household budget on health. Again, it's important to note how Sri Lanka has among the lowest levels of catastrophic health spending in South Asia. And that is indeed a remarkable achievement. Our review also highlighted several other issues regarding the urban health context. One is the large number of populations, according to UN Habitat, almost 50% in Nepal, Bangladesh, and Pakistan living in slum-like conditions. In addition, we noted, the environmental degradation in terms of air pollution, the lack of green spaces, access to clean water, toilet facilities, all of these as important concerns for health in urban areas. But these concerns mostly, we would say, affect people of those socioeconomic groups, and hence this emphasis on addressing these inequities is critical. We used in our framework to understand key issues regarding the primary healthcare approach to urban health, we focused on 4 areas. One is on governance, second is on access to affordable and quality care, the third is on engaging communities, and intersectoral action. And these broadly map onto the main pillars of the primary healthcare approach. Starting with governance, our main finding was that urban local bodies, these are municipalities, represent the level of governance that's closest to urban communities. And yet, in urban areas of South Asia, urban local bodies are typically not strong. They lack technical capacity, they lack financing. There's limited support they get from high levels of government. And we feel that these are very important areas for strengthening, not just increasing financing, but also building the technical capacity. And in many of the countries of the region, there's a constitutional mandate for urban local bodies to provide health services, and yet they typically don't have this capacity to do so in an effective way. We also noted that urban local bodies should be the nodal agencies for urban planning. They often are on the periphery of urban planning, but they should be brought much more central to it, and there should be active citizen participation in urban planning. Moving on to access of affordable quality care, it's well known that public financing for health is low in the region, and that, of course, also applies to the primary healthcare space and in urban areas. We felt that expanding and strengthening the urban public sector for PHC services and programs, particularly in poor areas, is important. Countries like India and Bangladesh have done important work in these areas. For example, the National Urban Health Mission in India has a particular focus on bringing government-funded primary healthcare services to urban slum areas. Even several countries in the region, particularly India, but also we understand in Bangladesh, publicly financed health insurance offers another model of improving access to outpatient care, but also of reducing out-of-pocket payment. That's currently only for hospitals, at least in India, but there is the possibility, at least in theory, that this model can be expanded to cover outpatient services too, of course, for people who are poor. We also find that engagement with the private sector providers is important, particularly those private sector providers that serve the urban poor. We found in our review that studies have shown that residents of urban slums, even though they have geographical proximity to formal care providers, often seek care from informal providers. And so engaging with informal providers for improving quality is important, as well as with formal providers. There's examples in Bangladesh, for example, the urban primary healthcare project in Bangladesh is one example of where formal private providers were contracted by the government to provide affordable healthcare to people, urban poor. Coming to the other 2 pillars of the PHC approach, we found that community engagement strategies have not, by and large, realized their full potential. As I mentioned, in some countries like India and Bangladesh and possibly Sri Lanka, we see that there's been a formal, systematic effort to reach to poor urban communities. But yet these models that have been used are largely rural-based models. And so we feel that it's important to think and conceive of urban-specific community engagement strategies and models. In the area of multi-sectoral action, which again is a very important focus area for the primary healthcare approach, we find that very limited efforts have been made in this regard. We see some efforts done, for example, in terms of smart city programs in India, Nepal, Bangladesh, Pakistan, and Bangladesh. There's the Jaffna Health City program also in Sri Lanka. But these have sort of been one-off programs, and our review of these programs seem to indicate that health was often not the central focus, and they, even within when health was also included in these, for example, smart city programs, they were as one-off programs, but not as in an integrated manner. So much more work, we believe, needs to be done in the urban context for multi-sectoral action, as well as for community engagement. Lastly, I wanted to leave everybody with an example of how the primary healthcare approach can be successful in addressing urban health concerns in South Asia. And I wanted to take us all back to the time of the pandemic, the COVID pandemic, and a place that might be well known to many of you, and that is the largest slum area in Asia, which is Dharavi in Mumbai. And Dharavi in Mumbai was in the news a lot for very good reasons. It was expected to be a COVID hotspot, and yet COVID did not devastate this community of more than 1 million people the way it was expected to. And this is because largely of the efforts of the Mumbai, the Brihan Mumbai Municipal Corporation, which essentially, at least in my opinion, used elements of a primary healthcare approach to tackle this pandemic in the slum area. And they did so by extensive contact tracing, establishing community clinics, partnerships with civil society organizations and private providers, collaborating closely with local community leaders and organizations, and also engaging local people as volunteers to support their efforts. All of these are elements of the primary health approach, and I think the success of what they achieved in the slum area is remarkable. In our paper, we also highlight examples of such successes from other countries in South Asia. So by no means is this the only example, but there are several others, and they're really interesting and worth looking at. Okay, so with this, I will end the presentation on the urban health paper, and I'll turn the presentation over to Dr. Kausar Afsana. She's professor at the BRAC James P. Grant School of Public Health, BRAC University in Bangladesh, and she's going to discuss strengthening primary health care through community health workers in South Asia. Dr. Afsana, over to you.
Thank you, Krishna. This is the fourth paper of our series, and we all know that South Asia has a very rich history of using community health workers and to bring the health care closer to the communities. But the growing health challenges in South Asia require adaptations of community health workers program as a key element of primary healthcare to deliver healthcare services to achieve universal health coverage. So the objectives of this study is one is to provide a comparative analysis of community health worker programs in 5 countries in South Asia, examine successes and challenges of CHW programs, suggest reforms to better ensure highly performing CHW programs. So in the method we used to narrative review, extracting data from peer-reviewed and grey literatures. We also did informal interviews with the experts from the countries, and we focus on major public health sector community health care cadres in the 5 countries. but only in Bangladesh, we include the public sector community health care workers, but also from NGO BRAC. So in my next slide, actually, we have developed a framework. Within this framework, we try to, it's adapted one, and we have few key themes here. Key themes, one is CHW capacities, empowerment of CHWs, CHWs performance and motivation, and sustainability. I am not going to go to each of them, but I would like to summarize that all the key themes that I actually highlighted here. So firstly, that we have seen that the CHW's role is changing. You have heard about the PSC's role, and you can see that accordingly aligned with that, CHW's role is actually changing in primary health care from community health promotion, firstly in different maternal, newborn, child health, and then family planning, immunization, communicable disease, and then we have seen that they have moved to management. In maternal, newborn, child health, you have seen that how they are involved in managing different issues in this care, and also in communicable diseases. Then what we have seen that slowly, as you have seen, we heard that the epidemiological transition and demographic transition, of course, the NCD is coming. The community health workers are slowly engaged in NCD screening, and also especially in diabetes, hypertension, and also in some countries, also cancer is screening, and of course, referral to the health facilities. And this role actually shifted in many different areas. And now that we heard about urbanization, we heard about many of the issues, emerging challenges coming about the geriatric care, and we heard about the COVID-19, that how COVID-19 actually the community played role. So the role of community health worker is also quite immense. And in all the countries, we have seen that the community health workers are more or less trained with the foundation training. But unfortunately, you know that you always need a good refreshers training or supported training, supervision. That is missing across all the countries, except some of the countries that Sri Lanka is one of them, and also a lady health worker supervisor in Pakistan. They have a good system of refreshers training. But in fact, you know, even though you need to have more, but what are the problems actually happening in terms of having all those things? We have seen that, you know, in the training and supervision, we can see that there is still, you know, we need to invest more in training, or also in having a strong supervision system. And then we have seen that, you know, with that training and supervision, and also the capacity, roles and responsibilities, we have seen that, you know, their community health workers actually significantly contributed to the performance of what we have seen in our health coverage, our knowledge in the community about health care, about awareness, many of the things. But because of, you know, as they said, that our health function system, as you heard from the previous speakers, these are all critical issues to support the community health workers. And community health workers, one of the strengths is that, you know, we also speak a lot about the empowerment issues, that how empowered the community health workers are, and they're viewed in the community as a, you know, agent of change. And many of the things we have seen over the years among the community health workers. But unfortunately, you know, some of the issues also happen in terms of, you know, especially in the hierarchy of the health system, their linkage with the health system, and how much support they're receiving from the referral system they're sending patients. So these are critical issues that sometimes also not empowering the system that exists in the community, where actually community health workers are playing a critical role. And in addition to this, we have to see that we have also witnessed in our review that community health workers' motivation is one of the key important factors, where community respect, trust, financial compensation, I mentioned about support from the health system, and career opportunities. But everywhere, at the end of the day, we have seen that our community health workers are more or less, largely, these are sustainable program in all the 5 countries. But we also observe that the payment is still low. That is, the low remuneration is actually also demotivating our community health workers, to perform and improve the coverage, health coverage. And another reason is that there is no career progression opportunities for the community health workers. So that also work as a demotivating factor for the community health workers. And there is also some areas there is high attrition rates. In terms of the sustainability, what we observe that, as I said, that more or less our community health worker programs are funded by government. But previously we have many examples that, that a small funded program, how it died away and didn't carry out through the whole health system. But on the other hand, I can give an example from Bangladesh, especially from BRAC, that still the BRAC it's an NGO. They're running that innovative and entrepreneurship model to design the maximize the sustainability of the community health worker program by recovering some of the cost, by delivering low-cost care to the marginalized communities, and they're charging fees, and they're also giving some. The community have many different cadres of health worker. I spoke about 2. I didn't mention, but 2 health cadres. So there are different ways of financing them. So this could be an example for other countries to see that how this program is running, and that also help also many government systems that you can also use a different model to sustain and carry out the community health workers program. So this is not in nutshell the analysis we have done. But based on our analysis, we found many research gaps, and we also have some opportunities that what we can do in future. So what are the research gaps? So there is actually a dearth of literature on how current roles and responsibilities, training, remuneration, career growth influences community health workers' performance in primary health care, and also their contribution to universal health coverage. So that means that the current roles and their future roles in different areas, the existing RMNCH, communicable disease, and mostly in the NCDs, the emerging problems that is coming, there should be a research that we need to investigate comprehensively to understand how best we can position community health workers, how best we train them in the PSC system to promote health and manage emerging diseases and disabilities. Secondly, that given the CHW's responsibilities, training, quality, cost, and community expectations, there are many things I spoke, but CHWs need to be better understood. How can this be done to ensure a fair distribution of tasks? How can you maintain the good quality of care and better health outcomes? We all talk all about this, but there is not much enough evidence to understand that how those community health workers are contributing to the community. So that means we need further exploration. And little is also known about the gender influences of the community, how the gender influences the community health workers' performance and their roles and their position. And because most of the community health workers are female, and they are also subjected to system-induced gender biases. So it's also important to understand that how this is happening. And on the other hand, there are also male CHWs working in some countries, and we need to understand that how they confront gender stereotyping issues in their work environment. So in this combined role, men and women CHWs working in different communities according to the need and context. So we need to understand that how they are interacting with the health system, how they are being treated, and how both the community health workers, male and female, are interacting with each other, given the emerging health problems that is coming in the future. So in addition to this, we also need a well-designed impact evaluation studies, and including economic evaluation should be considered for a newly designed community health worker intervention in South Asia. So in addition, we also need to do implementation research for this, and this digital revolution is going on at the same time, and community health workers in many countries they're using. So this should be captured in this kind of study to understand better that how the community health workers contribute more in delivering healthcare services in PSC and also to achieve universal health coverage. So major CHW programs, we have seen that, that is going on in our countries. In Sri Lanka, it started in 1926. Can you imagine, over almost 100 years back? And now in most of our countries, it's maybe 4 decades or 5 decades. But, and they are largely sustained. But we don't know that what are the evidence that we always, say that they're sustained? How we define sustainability? Is it financial sustainability, behavioral sustainability, programmatic sustainability? That needs to be understood better. So that means that we need to do a good research and also do a process documentation of the major successful programs on CHWs. So in the next slide, I would like to speak about that what we can do in terms of creating new generation of CHW programs. CHWs, as I said from the beginning, that CHWs are transitioning from broader role from RMNCH and communicable disease to NCDs, urban health, aging populations, but we don't have the enough supportive system and enabling environment for them to work, and that is really critical for them to perform better. And secondly, that CHWs in South Asia, we heard that, during COVID, that how heroic role they have played in mitigation of COVID-19 pandemic. Even in Bangladesh, we have example. But using CHW's strength by engaging them in the early warning system for disease surveillance outbreaks, I think these are critical issues to think about, that how they can be involved, not only in this, many other different diseases, and their roles in strengthening in their roles in the vital registration system. In many countries, actually, they're being used, but this is also not really strong system. So that's really important for us to do. And home visitation, that CHWs, they go home to home. But on the other hand, we also talk a lot about digital platform. But from our experience, we understand that, it's so important for human communications, human touch. It's really important. And that's why, the CHW's acceptability in the community is so high. So that, keeping that in mind, we should have an important interventions, that how we can expand CHW contact with every household. So that will also involve CHWs in terms of improving the coverage and their performance, and also their connectivity with the community. And linking CHWs with the health system, the better integration of CHWs in the health system is also important. And that is also will be possible if community health workers work more closely, if they are also well respected. That means very good systems need to be developed for them to be integrated within the primary healthcare systems in a better way. And in urban areas, as we heard from the previous speaker, Krishna, that how important urban health and primary healthcare, but their role in urban health is really, really very little in many different countries, except India, I think. So this is important to be considered, because without community health worker, it's impossible for any country, South Asian countries, to address the urban health challenges. And CHWs, lastly, we also need to respect them, because respect is, of course, the better remuneration, their career development, and we need to develop a greater enabling and satisfying environment for the community health workers to perform and to meaningfully contribute to the primary healthcare system. So that's actually the end of my presentation, but I would like to also reiterate that for that, we need to have commitment, and that commitment should not only the political commitment, it should come from the country, should come from the community. Everyone should be involved in this commitment that we need community health workers to perform, and also investment. So commitment and investment, I think that would also strengthen our community health worker in South Asia and help them to perform effectively in primary health care so that we can achieve universal health coverage. So I'll stop here and thank you so much. The next speaker is Sudha Ramani, and she'll be presenting the last paper. Thank you. Sudha? Sudha, are you there?
Are you able to hear us?
Where is Sudha? I can't see here.
Okay.
I can't.
Susie, can you hear us? Susie or Sudha? Seems to be a lot of technical issues today. Maybe in that case,
I can hear, yeah.
Okay, Susie. Okay, can you continue with the presentation? We're not able to read Sudha.
Can you hear me now?
Yes, we can hear you.
Yeah. Okay, so this is the last paper in the series, and the future paper, we are actually trying to bring in all the elements from the different paper series and tying it to what the future may look like for the region. So as we know, we found that all governments in the region have strong commitments to PHC. However, there are so many challenges that remain, and I think they have been highlighted in all the papers. But there are more challenges that possibly which we captured in the future paper. There is also a global push for UHC, and sometimes this is bringing challenges to these countries to fall in line with them. So that's another area that we saw, that these global pushes need to be, it's challenging to customize these global challenges for the countries. Of course, there are simultaneous country-specific actions which need to come in at many levels to address primary health care. And that is seen at the different levels. These two were captured in the series. So we followed extensive methodology over the last 2 years, synthesizing from the paper series, but also with cross-learnings between the experts and also opening it out to a wider group of experts, where we came to the ideas of the paper looking at not only the case studies, as we may call, from the different papers, but also looking at cross-cutting issues, which emerged as the action points in these in the future paper. So the main action points, we could call them as 9 areas. If I may just read out, one was it was important to align the policies on PHC with the national and subnational needs and the capacities. So this is very important to align all the policies on PHCs with the national and subnational, because most countries had a decentralized situation. Scaling up to increase public financing, improve efficiency of resource use for better financial protection, strengthen governance capacities of ministries of health, strengthen the health workforce and service delivery, private sector partnerships towards policies on PHC. So concluding, the existing policies on PHCs must be reevaluated and strengthened in ways that match the evolving priorities, which we could see that communities and available resources need to be considered in the light of the different transitions that are happening. The 9 cross-cutting action points in these papers and the recommendations from the series papers are all important in offering a pathway in moving forwards. And of course, more research practice networks are required to inform the ongoing work.
Hello, can I be heard?
Yes, I can hear you.
So thank you to all our speakers for this rich and insightful discussion. Since my co-editor from the Lancet Regional Health Southeast Asia, Dr. Shalini Garg, and I couldn't introduce ourselves earlier, a quick introduction from me. I'm Dr. Kate McIntosh. I'm the Deputy Editor at the Lancet Global Health. I speak for Shalini and myself when I say we're so thrilled to be publishing this timely and novel series across our 2 journals. So we'll now move from those really interesting presentations to some of the questions submitted by our audience. So as a reminder, you can submit questions by using the Ask a Question box on the dashboard. So starting off, I think, Professor Rao, why do you think this is an opportune moment for this series to be published?
Thank you, Kate. I think there are several reasons why the series is at an opportune time for publication. One is, as we mentioned, and we saw throughout the presentations, that there's a need for new primary healthcare models for the region. And this stems from both the changing demography, in particular population aging, also the rise of NCDs in the region, and then the urbanization that is rapidly there in all countries in the region. So these are some of the key issues that in our opinion required new thinking in terms of new models of care. Typically, what we've seen that across countries in the region, primary health care is focused on maternal child health, and there is a need to move that to a broader focus to address these challenges. I think secondly, the COVID-19 pandemic also highlighted how critical basic health services are for dealing with pandemics. In several cities of the region, simple things like the lack of oxygen led to unnecessary deaths on a large scale. These are things that you don't need hospitals for necessarily, but a strong primary healthcare system could provide these in a very efficient, equitable way to people. And so that's, I think, a second reason to invest much more in primary healthcare systems. I think if you also look at countries that have improved health significantly, and I'm thinking of countries like Thailand and Costa Rica, they have done so by investing heavily in strengthening their primary healthcare services. We see it both in Costa Rica and Thailand, and I think for countries in South Asia that's again important. And finally, several countries in the region have a demographic dividend that they can achieve, but this won't be possible if better health is not also achieved. And I think, therefore, rethinking how primary healthcare can support that is crucial. But my colleagues might have other answers, so if they want to come in.
No one else. I think one of the things that really stood out to me about the series was how important this seems to be at a juncture, particularly for addressing non-communicable diseases. So I thought that was a really interesting thing to highlight. So to any of our panelists, in terms of another priority that came out there, Sri Lankan primary healthcare was noted as exceptional in several places throughout the series. What features about their care have made it a high performer for the region, and what lessons can other countries, both within and outside the region, apply to their own health systems?
Can I respond to that?
Yes, absolutely. Yeah.
Yeah, sure. Yes, actually, I think there are a few things that we need to consider on primary healthcare system or primary healthcare within the health system in Sri Lanka. As was very clearly mentioned in this particular series, our system for primary healthcare has a long history, much longer history even before Alma Ata came in 1978. So that system have evolved throughout with different services being going to the doorsteps of the people. Because most of the time when people are talking about primary healthcare in general, people look still at curative services that is being given, but less emphasis on preventive and promotive services. If you look at Sri Lankan system, the primary healthcare system was evolved basically on preventive and promotive, even from 1920s, rather than curative, because curative hospitals, dispensaries, and others existed. But the system of primary healthcare was particularly based on how preventive and promotive sector could be improved. That is where the community health workers, which is very clearly emphasized in our fourth paper, took the services to the doorsteps of the people, which means that people are engaged in those rather than people, because of the health-seeking behavior, approaching health centers. So these are two different things. Therefore, Sri Lankan system is catering primary health care from a different perspective rather than purely curative or mixed. It's more or less into the preventive and promotive service. That is one of the key. After 100 years, close to 100 years, we are showing that the system worked for a long time. I'm not telling that there are defects. I'm not telling that it's perfect, but comparatively for the 5 countries that we have looked at in this series, we see this particular element of taking services to people rather than asking people to come and access services has worked in our country. I think that is why all the indicators related to primary healthcare has a higher level, higher attainment in Sri Lanka compared to many other countries in South Asia, Africa, and some of the Latin American also. I think that is the issue and the main key factor that I think why Sri Lanka is much ahead of other countries. And if I can
Thank
add
you very
one more
much. So
thing,
it sounds, yep.
yeah, just one, I forgot one, that political commitment, the government taking primary care as a serious function throughout this 80 to 100 years has already contributed, but they take it as a serious responsibility of the government to provide primary health care services, not just keeping it to private sector. That's right. Thank you.
Absolutely. So prioritizing primary health care and certainly people-centered healthcare, I think, is something that really could be more widely applied across the world, definitely. So we've got a question in our chat that a high proportion of services were sought from the private sector. So someone said, why not acknowledge the public preference for private care more explicitly in your solutions? And I'd add, how do we make sure that private care is both safe and effective? Would anyone be able to answer that?
Well, I can chime in here. And I guess it is true, particularly in urban areas, the reliance on private sector care is huge, both within higher and lower socioeconomic groups, because of its availability. There are across the region very sort of weak primary healthcare systems, in urban areas. And so that reliance is there in the absence of good public health or primary health care services. And I think it's a real issue that there isn't more public provision. But they are there, and they're serving in proximity where people live, and they're serving according to what people sort of want from them as well, which is largely curative services. So I think that needs to be done in terms of bringing them into the system because of proximity, and there are there have been various sort of efforts to think about sort of training private providers to deliver greater quality, but the reality is that they do involve out-of-pocket payments, which may be impoverishing, and they're not necessarily promoting preventive measures as well, because there's less incentive to do that. So I think there's a lot of work that needs to be done sort of in terms of bringing the private sector into the fold, particularly around non-communicable disease prevention, promotion, that needs to be thought through seriously. And that involves, obviously sort of policy engagement as well.
Great, thank you so much.
Krisha, maybe you want to meet that.
Can I add to that? Could I add to that? I think it's important that governments do recognize the place of private providers and try to ensure that it is safe and there's a space for private providers by ensuring quality, but also trying to have a financing arrangement where the people don't really have to pay at the point of care. So there are different ways in which private providers can come into the space for providing services, especially primary care. But this is something.
Thank you so
probably
much. Great, thank you so much. So I think that's probably all the questions we have time for today. Shalini, were you able to join us? Sorry about all the technical issues.
Hello. Hello, thanks, Kate. Can you hear me?
Yes, yeah, we can hear you.
Oh, thank you. So thank you so much, Kate. And we are really sorry about the technical issues that we had to experience today. So thank you all for joining us today and sharing your insights and experiences. We know that investment and in PHC can deliver equitable, efficient, and cost-effective care, and that insufficient investment can hamper patient trust, utilization of primary care services. We now also have evidence supporting the expanding and scaling of successful interventions that could draw strength from examples such as Sri Lanka that have shown that even in low income contexts, sustained commitment to PHC can improve population health and healthcare. So today we have covered a lot of topics concerning primary healthcare, and I'm glad we can end this conversation with some hope, and collectively we can make a change. I would like to extend my heartfelt thanks to our speakers, Professor Krishna Rao, Dr. Shankar Prinja, Dr. Kausar Afsana, Dr. Sudha Ramani, Dr. Elaine Adams, Dr. Suzy Pereira, and Dr. Manoj Vikramsinghe for their participation and an engaging discussion. It's been a privilege to hear from speakers from such diverse backgrounds. I hope our audience has found this webinar inspiring and that the messages are helpful to inform your work. And also we have learned that through collaboration and focusing on solutions and actions, we can move the needle on new models from primary healthcare that are ready for today's and future's challenges. I cannot end this webinar without thanking our marketing team, without whose support this webinar would not have been possible. And finally, thank you for listening patiently and engaging actively in the discussion. So if you want to explore the series more, please click on the related resources box at the top of your dashboard, and that will take you to the Lancet document. So thank you very much again, and take care. Good night.